you're going to measure abduction,
ASIS.
ASIS. Okay. All right, so let's move on to the knee then, since we're done with the hip. Maybe. Technology's wonderful. Maybe I need to turn the clicker on. All right, so let's look at the joint structure and the motions that happen at the knee. So, what are the motions of the knee? Flexion, extension, done. Let me say that one more time. Flexion, extension, done. Okay, don't be trying to measure rotation at the knee. If you're you do use the knee as your axis point for measuring rotation at the hip,
Right.
but we're not going to measure rotation at the knee. Okay, so it could be said that the knee is a complex joint. It's differently complex than the hip. You know, obviously it just moves in one plane instead of three. So that's a little simpler, but the knee is actually supported and maintained by muscles and ligaments, and so there's not a lot of bone stability. And so that exposes it to severe stresses and strains. So it's one of the most frequently injured joints in the body because it really is only made to flex and extend, and yet sometimes we get lateral forces. Either, I mean, you know, the first place you think about is sports, football, where they get hit from the side and trash their knees. Okay, but the reality is that if I'm walking along and I fall off my high heels, I still create that lateral shearing effect in my knee. It translates all the way up. So it affects my ankle, but it will also affect my knee. And in a little while, we're going to see how your foot position can actually affect your knees all the way up. Okay, so it's considered the largest joint in the body. It's a synovial joint, and it's a hinge joint. It's a hinge joint because it just does flexion and extension. There is a rotational component that accompanies the other motions. It's not something, this is arthrokinematics though. It's not osteokinematics, it's arthrokinematics. And so we're not going to actually measure that rotation because it's really very slight, and it's just a little bit of rotation. Part of that is to keep you from trashing your knee every time you walk. Okay? So here's our motion. So extension is going to be 0, flexion is going to be 120 to 135. So comparing that to the arm, the knee is kind of like the elbow. Okay? One bone up top, two bones down bottom, flexion, extension. That flexion is going to be limited by soft tissue approximation. Okay, so if you're fluffy or muscular or really skinny, that can change what your maximum range of motion is. Okay, so we've got actually quite a range of what's normal, 120 to 135. Okay, so this would be a place where you'd want to look at both. If one side is affected, you look at both sides to see what's normal for that patient. Use your best clinical judgment. You can see when that soft tissue approximation is occurring.
So when we document the flexion, we want us to do 120 to 135.
No. That's the normal end range. The end range could be as little as 120 or as much as 135.
So it'd be 0 to 1.
So it'll be 0 to, or in the case where the knee doesn't fully extend, it'll be whatever your beginning measurement is to whatever your ending measurement is.
So it's
Okay.
one measurement for 2 actions.
It's one measurement for 2 actions. So it's extension is how straight you can get it, to flexion is how bent you can get it.
You alluded to knee injuries a moment ago,
Yeah.
and I've always wondered, I guess everybody else knows because nobody ever asked, what exactly, you always hear about a blown out knee. What does that